Welcome to the Preventive Medicine podcast. Help us change the paradigm of medicine from keep people alive to help people thrive, one episode at a time. And now, here's the show. So, Austin, a lot of what you do outside of the 2 weeks when you're on that inpatient medicine is Barbell Medicine, correct? So can you tell us a little bit about what Barbell Medicine is, why you decided to start it, and like what the goals of that company are?
Yeah, sure. So I won't take credit as being a co-founder. It was entirely founded by my friend Jordan, who you mentioned earlier. But pretty early on in the process, when we ran into each other in medical school and realized that we had this shared interest, we started working together, and that progressively increased over time. So this was, I guess it would have been probably around like 2013 timeframe, something like that. And so the idea, we came from kind of an athletic background and had gotten into lifting weights. And as we went through the medical education and started to see more situations where kind of the exercise and lifestyle medicine, quote unquote, side of things could be applied to benefit patients, while at the same time seeing that it was probably being underemphasized relative to its importance. And so we kind of set out to serve as public communicators of this stuff. In other words, if their own doctors weren't up on this stuff, then we were going to try to deliver that message as broadly as we can to the general public, while at the same time also, by virtue of having attained this level of training and the professional degrees and things like that, that gives us some degree of like unique access to actually deliver the message to other clinicians as well, because they're more likely to listen to colleagues and things like that on these matters. So hopefully trying to influence both sides from the healthcare side, and hoping that might work its way up to broader kind of like policy type things and more public recommendations, as well as reaching the lay public on the importance of some of this stuff to improve public health outcomes.
Mm-hmm. Interesting. Are you able to actually? So I know a lot of it is coaching through Barbell Medicine, but when you're on like inpatient rounds, are you able to get people to talk about resistance training then, or is that kind of not the goal at that point?
Yeah, so I think in a lot of situations that's not necessarily the most immediate concern for somebody's like life or death.
Obviously,
if somebody comes in septic shock, you're not worried about how much they can squat necessarily. But in the back of my mind, I am thinking, after this septic shock gets resolved, how much they can squat does kind of matter, because that might influence where they end up going. We start deciding about where a patient is going to be, going post hospitalization, basically at the time they get admitted. And I try to do that assessment pretty early, and that might be a situation where I immediately know, unfortunately, this person doesn't have the physical capacity and they're going to end up having to go to a nursing home, which is less than ideal in many situations, versus, this person's in great shape. Once we get this resolved, they're going to be able to go back home to their independent life again. And so while, we're not necessarily talking about it up front at the time that they come in super sick, potentially, it is a pretty regular discussion where we're talking about, what is their physical capacity? If you were to give them recommendations, what might those look like? Are you, the intern, medical student, et cetera, aware of what the physical activity recommendations would be? Because the same people that I'm training in the internal medicine residency, they also have outpatient blocks, and they have a continuity clinic and things like that. So it's like, let's say that you're going to do this patient's hospital follow-up. What kind of things might you be discussing with respect to their, if they come in telling you, man, after that ICU stay, I've had a lot, harder time getting in and out of chairs, getting in and out of my house, getting in and out of my car, et cetera. How would you approach that problem? So there are a whole host of ways that we can work it into the clinical discussion, regardless of where we are, whether outpatient, inpatient, ICU, et cetera. And that's kind of what I try to do, is I work it in with the teams and also with the patients themselves, because I might, do a little sit to stand test with a patient at the bedside. And when I see they can't stand up, then that might prompt a discussion of, how come, what can we do about this? What kind of things do you want to be able to do? How can we get there? Things like that. Pulling a little mini motivational intervention at the bedside can be useful.
Makes sense. So with all these other interests you have, specifically, we're talking about weightlifting or powerlifting, that sort of athletic background. What made you choose internal medicine versus something that's more, like ortho, bro.
Or
PM&R. Can't forget PM&R in there for MSK medicine.
PM&R is legit, or it has the potential to be legit if people go about it the right way, I would say. So I mean, it was kind of funny going through a lot of the clinical rotations. Sometimes walking in, the assumption was that I was going to go into ortho just because I like lifted weights, and I wouldn't say that my ultimate path into internal medicine was related to my prior like athletic history. It was strictly my personality and thinking style and things like that. I mean, I'm personally, I just really enjoy knowing a lot about a lot of things and being able to explain the physiology, the pathophys, the pharmacologic mechanisms, the microbiology, whatever is going on. I like having a real deep understanding of that. And I like the process. I think probably in internal medicine, the process of differential diagnosis is like my favorite thing. When I can sit down with a student or an intern or a resident or whatever, and we have a patient presentation that might be vague or nonspecific or a bit nebulous up front. And we can work backwards through the physiology to figure out what are all the possibilities, where are all the steps where this could go wrong, and that might guide our subsequent evaluation and management. So thinking through those possibilities is like what I really enjoy doing, and teaching people to think that way is pretty enjoyable as well. And on the other hand, I am about as strongly disinterested in procedural medicine as you can get. I definitely hate everything about the OR, and so that was not a place where I was going to end up I would sooner leave medicine than end up working in an OR.
Really, it's that
bad? I'm just not a fan.
Yeah. So it's actually really interesting that someone has interests that are kind of not necessarily like diverging on opposite ends of the spectrum, but just like so much about internal medicine is not necessarily related to what you do through Barbell Medicine. And knowing a lot about the internal medicine side of things and just whatever goes into internal medicine and like barbell and strength sports and nutrition, all that is it's just a very broad amount of knowledge. And I think it's very unique that you have perspective that you can take from both sides and apply it to either your inpatient patients when you're seeing them on rounds, or taking your inpatient knowledge and then maybe applying it to some people you coach potentially. I don't know if you do that at all. I'm sure the perspective is beneficial, at least. Do you think that more physicians that do not lift weights can learn from Barbell Medicine what they're doing, or do you think they should like go to your seminar or something like that?
Yeah. So I mean, I think that there might be a bit of a branding issue there, in that when you call it Barbell Medicine, that might pigeonhole us a little bit in terms of what people might think that we do compared to what we actually do, which is a whole lot broader than just like lifting weights. So, the seminar that we teach is 2 days long. There's a whole bunch of lecture, and there's actual, lifting education, coaching that happen. But the overall themes that run through the seminar and the themes that run through all the other things that we do, the content that we put out, the educational material that we produce, I would say that they're revolve around three major kind of pillars. The first is kind of our idea of health and what health is. And there's been debates over the decades and centuries about what health is. And one of the more recent definitions that we like is that health is the ability to adapt and self-manage in the face of physical, emotional, and social stressors. And that idea of being able to adapt and self-manage is probably a novel concept with respect to health compared to what a lot of people might think of. They might think of it as like, oh, you got good blood pressure or something like that, right? Whereas the idea of self-efficacy as a theme for a healthy, robust individual to be able to take care of themselves in the majority of situations where that's feasible. Obviously, we don't expect them to self-manage their like ARDS or something like that. But in general, that concept is one overarching theme that we want to try to educate and empower people within their own kind of psychosocial, socioeconomic context to be able to do as much as they can, either for themselves or for their community, things like that. The second would be understanding how complicated most phenomena are. And in particular, when it comes to humans, probably one of the best ways that we have to view this, although itself still limited, is kind of a biopsychosocial approach where we understand the physiology and the biology, which is obviously I enjoy a whole lot, but also understanding that, when we're dealing with people, we're dealing with psychology, we're dealing with their own socioeconomic context, which presents new things that we need to think about and consider and that influence our plan, even if the underlying biology is the same between two different cases. Differences in the psychosocial context that those two cases are in can wildly alter what you end up doing or recommending for that person. So avoiding that reductionist perspective on things where you might isolate somebody down to their ejection fraction, instead realizing that they're a human and that maybe their medication adherence for their low ejection fraction is really complicated and is due to a whole host of factors that need to be considered, and we need to give them the self-efficacy to be able to self-manage that. And then the third, to tie all those things together, is just the idea that most of this stuff that we're doing and promoting has to do with behavior change and how we go about promoting behavior change effectively. There's obviously a lot from a clinician standpoint, things you need to know, be aware of, as well as communication strategies, delivering narratives to your patients in ways that resonate with them and that will most effectively move them through these kind of the stages of change, as far as like a model that we have to conceptualize it. Although, of course, it's even more complicated than discrete stages. But being able to communicate with people at their level to help guide them through the process is a very difficult skill set to develop, and I think is also underemphasized in the course of medical training. So those are kind of like the big three themes that we have in our content. And I definitely would say that across the spectrum of physician specialties, regardless of what field you end up going into, those are overall good things to be aware of and potentially even competent with, depending on your degree of direct patient interaction. Like a hematopathologist's abilities to effectively perform motivational interviewing, not necessarily the most critical thing, but at the same time, recognizing that they're dealing with a person on the other side of that slide might still have some utility. Sure. And of course, now we're seeing these days with pandemic medicine where people are getting pulled across specialty lines and all kinds of things. There's no situation where these skills would be a waste of time or unhelpful. So we definitely recommend getting familiar and comfortable with these ideas. And we've designed the seminar to be accessible to both lay people and to be useful for clinicians as well. And
that was kind of my next question is, do you find, having been to one of the seminars myself, I can definitely speak to how much it helped my knowledge base in terms of going forward as a doctor in training. But do you feel like as you do more and more seminars, that the population of them starts to trend one way or the other in terms of, lay people versus professionals? I think we're seeing a pretty consistent composition. We're probably seeing about 3/4 lay people, 1/4 healthcare professionals, and that might nudge a little bit one way or the other, seminar by seminar, depending on the location. But I think that, we've only been doing it for, maybe 2-ish years, something like that. And so there's definitely a long way to go in the future. And if we can, we may end up in a situation where we need to split them off into 2 separate deals, one for healthcare professionals exclusively and one for lay people. I'm not sure yet what direction that'll go. But obviously the people who do come through from the healthcare side, they end up leaving very enthusiastic and excited about this stuff and ready to help spread some of those ideas in their own local areas, which has been cool. And then additionally, sometimes that has then prompted them to maybe invite us to go speak at their respective institutions or places, which has also helped spread some of these ideas even more, which has been great. For sure.
Preventive medicine is an incredibly important topic. I want to thank you for taking the time to watch this video. For the full episode, find us on your favorite podcast streaming platform. If you enjoyed this video, don't hesitate to hit that subscribe button, like this video, and share it to keep that message spreading. Thank you once again for watching this video, and we'll see you in the next one.